Good evening, and thank you for joining us. We live in a country where there are observances for every medical condition in each month of the year. In many cases, there are multiple conditions being observed each month. For example, September is Sickle Cell Disease and Prostate Cancer Awareness Month. September is also Blood Cancer Awareness Month. Now, you might be asking, what is blood cancer and what does that have to do with me? Well, I can answer the first question rather easily. The second question is what we're here to answer tonight. Okay, so here's the easy part. Most blood cancers start in the bone marrow, which is where blood is produced. Blood cancers occur when abnormal blood cells start growing out of control, interrupting the function of normal blood cells, which fight off infection and produce new blood cells. Tonight's topic, multiple myeloma, is a type of blood cancer, along with its more commonly known partners, leukemia and lymphoma. The next question could be, why are we talking about multiple myeloma instead of the other types of blood cancers? It's another good question. Let me ask you this. Did you know that Black Americans are at twice the risk of developing myeloma when compared to other racial and ethnic groups? Did you know that Black patients are often diagnosed at a younger age, likely to have higher hospitalization costs, less likely to participate in clinical trials, face more delays from diagnosis to treatment, and face significant barriers to access timely, optimal treatment and care? If you know all this, I hope you have become an advocate. If you didn't, thank you for joining us and sit tight. We're going to explore myeloma in a way that will have you prepared if you or a loved one are faced with a diagnosis. So I know y'all didn't sign on to hear me talk. So we're going to introduce our guest. Our first guest really needs no introduction. This is Dr. Craig Cole. He is a board-certified hematologist and serves as a director of clinical research in hematology, oncology, and multiple myeloma at Michigan State University College of Human Medicine at Breslin Cancer Center. Dr. Cole is an award-winning educator, has been published in national journals, and has been the on-site primary investigator for over 30 clinical trials and participated in over 50 clinical trials in multiple myeloma and malignant hematology. Dr. Cole, welcome to the program.
Thank you so much.
Our next guest is Dr. Joseph Mchale. Dr. Mchale is a professor in the Applied Cancer Research and Drug Discovery Division at the Translational Genomics Research Institute, an affiliate of City of Hope Cancer Center. He is also the Chief Medical Officer of the International Myeloma Foundation and Director of Myeloma Research at the Honor Health Research Institute. Good evening, Dr. Mchale.
Good evening. Great to be with you, my friend.
And finally, along with us is Mr. Brian Daly. Brian is a community outreach manager for the Leukemia and Lymphoma Society. Brian is a multiple myeloma survivor and staunch advocate for closing the disparity gap in healthcare. Diagnosed in early 2018, Brian went through several months of chemotherapy leading up to an autologous bone marrow transplant. Since his diagnosis, he has taken up bicycling and dedicates his time to speaking publicly about the importance of self-advocacy and risk mitigation related to health and wellness. Brian, welcome to the program.
Thank you, Ellis. It's a pleasure to be here.
All right, so now that we've got all the particulars, last thing I want you to do is let us know where you're watching from. We'd like to know where everybody's watching us from, so drop that in the comment section. Also, if you know somebody that needs this information, please tag them and share this on your page. This is valuable, life-saving, and life-changing information. So share this on your page, tag a friend. And finally, if you have any questions throughout tonight's broadcast, please drop those also in the comments, and we will get them asked and answered if time permits. First up, let's start with you, Dr. Cole. For my sake and for the sake of our viewers, could you explain what multiple myeloma is and why we should know about it?
Yeah, and really, you really touched on a lot of those points already, and so it makes my job pretty easy. But inside the bone marrow, just like you had mentioned, it's the blood factory, and inside that blood factory, we have the white blood cells, and which are part of our immune system. And among the different types of white blood cells, there's a type of cell called a plasma cell. And so that helps produce antibodies, which can then help us fight off infection. And just like any other cell in the body, just like a lung cell or a colon cell, those plasma cells inside the marrow, when they become cancerous, we call that multiple myeloma. Multiple meaning that those plasma cells will grow inside the bone marrow, start to take over parts of the bone marrow, so the blood counts start to get low because the factory is being consumed by these cells. And then the multiple part is that those plasma cells will then leave the bone marrow, and they have an affinity for bone because they start out in the bone marrow. They have affinity for bone, and then they'll go to areas of the bone, multiple areas in the bone, and cause that bone to weaken. And so we use a mnemonic called CRAB to have us recognize when people have myeloma. The C standing for calcium, that when those myeloma cells go to the bone, they release calcium into the blood, so the blood calcium can be high. R stands for renal or kidney damage, that being part of the immune system, those plasma cells will produce lots of protein. The kidney is supposed to filter that protein. The protein gets stuck in the filter and causes the kidneys not to work well. So kidney problems. A stands for anemia. Again, that those plasma cells take over the bone marrow, so you don't make blood very well, so people become anemic and fatigued. And B stands for bone disease, where again it causes holes in the bones, which can cause the bones to fracture or to be weak, which can cause pain. And the way that we can detect it, and that we'll talk about in a second, is look for that protein in the blood. Can help us find and detect myeloma.
So, Dr. Mchale, what are some of the risk factors that increase a person's chances of developing multiple myeloma?
Well, thanks, Ellis. And I think you identified perhaps the most important one, is that myeloma is twice as common in people of African American descent. So we know that myeloma, as Craig mentioned, is a cancer of these plasma cells that grow in the bone marrow. And it's not a particularly common blood cancer or cancer in general. When you look at all cancers, myeloma is somewhere about 1.5% to 2% of the total. But it's significantly higher in patients of African American descent. So that's really kind of risk factor number one. Risk factor number two is we do see a little bit more in men than in women. So although we obviously see myeloma in women, it is slightly more predominant in men. Thirdly, it is more common as we get older. So the average age of diagnosis is around 70, but in fact, there are certain groups in whom we see it younger. Indeed, we see the average age about 5 years younger in African American patients, around 65 or 66, and even actually a year younger in Hispanic and Latinx Americans at about 64 to 65. So age makes a difference. Outside of those three big risk factors, there are just a couple other things that are really, really small, much less common, but we should probably know about, that sadly there are associations with myeloma in patients that have had very certain toxic exposures. We see increased incidence of myeloma in patients who were exposed to Agent Orange during the Vietnam War. We see it in patients that were exposed to certain toxic chemicals that include people who are firefighters. We even demonstrated through the International Myeloma Foundation that there was increased incidence of myeloma, sadly, in those first responders back at 9/11. But for the majority of individuals, there isn't, if you will, a known cause. It's not necessarily associated with smoking. There's some association with obesity, but it's not really a disease that we know its exact cause.
So, Dr. Cole, are there some signs or symptoms, a cough, a nagging pain, something that we should be looking for that could, ring that bell to say, hey, maybe I should go get screened for myeloma?
Yeah, that's a super good question, because myeloma is the great masquerader, and that's the problem. That those crab things I talked about, the high calcium, the kidney problems, the anemia, all that starts with fatigue. So if you start having, and I tell people another mnemonic is think back. The B stands for bone. If you start having unusual bone breaks, or if you start having a pain in the back, or you start to have fractures in the bones that are unusual. That is a sign for myeloma that you should ask your doctor about. The A, again, anemia. When people are fatigued, so if you have unusual fatigue, or if your doctor says that you're anemic, anemia isn't a diagnosis in of itself. Anemia is always due to something. And so you need to work up that anemia. And part of working up that anemia is looking for myeloma. The high calcium level, that will have people again feel fatigued, but they'll have frequent urination. People can have frequent urination with diabetes, but they can have frequent urination with high calcium levels. And again, easy blood tests to look for that. Fatigue and frequent urination. And then with the kidney disease. One kind of interesting thing, sometimes people will have foamy urine. They'll have urine that has a lot of foam in it because that protein is getting stuck in the kidneys from myeloma. And then you start to pee it out. And so again, that can happen with diabetes. But if you start to have kidney problems, one thing you should easily rule out is myeloma. But the biggest symptom a lot of people have is fatigue. The other thing is infections, because remember, this is a cancer of the immune system. Okay. And so if the immune system has cancer, and in the same way, if you have lung cancer, you have trouble breathing. If you have myeloma cancer, you have trouble fighting off infections. And so having unusual infections or frequent infections is another reason you should look for myeloma.
I just want to add to that, Craig, you said it so well that when you started with that great masquerader, this is a problem. Nobody comes on with a sign on their head saying, "Hey, I got myeloma." Right? I mean, it's not how it gets found. Very occasionally someone may have some other blood tests and it kind of points in that direction. What I call incidentaloma, where you incidentally find it. But more often than not, it's been growing for a while. And I know we're going to be talking about the disparities later, Alice, and I'm not trying to jump the gun on you, brother, but this is such an important point because the average myeloma patient, independent of their background or race, sees their family doctor 3 times with signs and symptoms consistent with myeloma before the diagnosis is made. We know that this is even longer in African American patients. Why? Because there are a whole series of reasons: access to the system, trust in the system, but even from a pure medical standpoint, Craig noted it quite nicely, there is such an overlap between myeloma and diabetes. And diabetes, of course, is more common within the African American population. So how many of our myeloma patients, I'm sure, Craig, you have the same experience, they were told for a long time, oh, that anemia, that's your diabetes. Oh, a little bit of protein in your urine, oh, that's your diabetes. A little bit of neuropathy or numbness and tingling in your hand, oh, your kidney function, that's all a function of the diabetes. And so we should really be on the alert, whether we're in the health profession as primary care doctors that are seeing these patients and in the community at large. When those things are coming up that Dr. Cole has mentioned, we should have on our radar screen myeloma, especially in Black patients, where we know, as we've said, that our risk is twice as high compared to the Caucasian population.
It's interesting because we do a show every other Friday called Kidney Talks, right? And we have transplant surgeons, Clive Callender, Joseph Mchale come in from George Washington, and they talk about renal failure. And so when I hear you talking about that, Dr. Cole, and I hear you talk about that, Dr. Mchale, what I'm hearing is all of those things that they've been saying on that program: foamy urine, protein. And so somebody could really feel like a doctor could get those symptoms and point them towards a kidney specialist and totally miss the fact that they have myeloma. Brian, I saw you shaking your head up and down. As a survivor, what was your experience? How long did it take for you to get diagnosed?
Well, for me, I was very fortunate in that I had a very good primary care physician team. And the way I was diagnosed was he was following some simple lab tests, my blood and urine. And he noticed there was an elevation in my both my blood and urine and my protein. And didn't quite know what to make of it. So after a few months of retaking those tests, he noticed as it was scaling up, it's probably time to visit a specialist. So he recommended first a urologist, a hematologist, a nephrologist, and then ultimately an oncologist. And that was sort of a telltale sign. However, what really convinced him that it was something deeper than any of the diseases that Dr. Mchale or Dr. Cole had mentioned, diabetes or anemia. I was in a gym one day and I was playing basketball. I fractured my finger thinking it was a sprain because I didn't really injure it that severely, in my opinion. And I've had that type of injury in the past, and it always healed after about a week. It took about 2 weeks, and my primary care physician ordered a skeletal exam. It turned out to be a fracture, and he was able to take that data along with the fact that my protein levels were elevating, and it took probably a matter of 2 months, from the time he made that conclusion, and I visited those other specialists that I got diagnosed after a biopsy with myeloma.
It's interesting to hear like that patient survivor experience, because the one thing that I want to point out to our audience and what Brian just said was he kept going to those follow-up appointments, right? He went to a nephrologist. He went to and if they're not finding any solutions from a patient standpoint, that could become very, very frustrating, and you could stop, right? We could have that point where we just say, you know what, those doctors don't know what they're talking about. I'm fine, and they keep moving on, and then then the disease can advance. And so there are some great comments that are coming in. People are talking about family members. Somebody said their mom was 72. Another one said they got diagnosed at 52. So to Dr. Mchale's point, people are getting diagnosed earlier, especially Black folks are getting diagnosed earlier. And there really is a community out there that the people that need this information. So Dr. Cole or Dr. Mchale, either one of you, what is that moment like to really go in? Because I think people hear about somebody getting diagnosed, but what is that moment like as a physician to have to go in and tell somebody that they have myeloma?
Yeah, that's always a tough point, and because it's always a challenge, because when someone is diagnosed with lung cancer, I keep picking on lung cancer. If they're diagnosed with colon cancer, you can kind of picture that in your head.
Right.
When someone's diagnosed with myeloma, of course, it's a shock. And then really, our responsibility is to educate and empower, and really start, that moment is always a shock. We talk about it, and then it starts the education process about this is what it is. This is how you communicate it to your family. This is how you communicate it to your friends. And then we start working on education and empowerment. Right off the mat. But that's always a really tough. The part of my day that hurts the most is when I have to diagnose somebody with myeloma. But one thing I should mention real quick is that to diagnose myeloma, just to the screen is just a few blood tests. You just look for that protein in the blood. There are 2 tests: a serum protein electrophoresis, long name for work that looks for that protein, and a serum free light chain test looks for fragments of that protein. Those 2 tests can screen for myeloma, and it won't even confuse anything else, because myeloma has a very particular look with those 2 tests.
Okay.
And if I could just add to that, it's brilliantly put, Craig. And it's so important that those 2 tests get done, because historically only the first test was done,
Mm-hmm.
and that'll miss about 1 in 5 myeloma patients. So for anyone involved from the primary care world, that really is important that you pair that serum protein electrophoresis with the light chain measurement. The other feature that I'll add to what Craig said on that first moment, that it's so challenging and so tough to share that with a patient. No one ever likes to tell someone they have cancer, let alone a cancer that most people can't spell and don't understand and need time to have education around it. That being said, we have come so far in this disease, and we're not trying to be competitive per se between us, but I can't think of another cancer that in the last 15 years has had the advances that myeloma had. I mean, I went into myeloma Some of you were still pediatric at the time, but I went into myeloma when 25 years ago. And at that point, most of our patients lived 1, possibly 2 years with this disease. Most people had horrific bone disease. Many people had back braces. The whole clinic looked like people hunched over with back braces. Now, there are exceptions, of course, to the rule, and there's only averages, but the average myeloma patient will actually live more than a decade. And although we haven't cured it, we've come so much more in line with controlling this disease. You know, we haven't cured high blood pressure or diabetes, but we control it for a long time. And so it is very exciting. And now with some of these new therapies that we do in our clinical trials, which I'm sure we'll get to, Ellis, I mean, it really has revolutionized the way we think about this condition. We're not just using the old school chemo anymore. So I like to, at that very first time, having that conversation with the patient, you know, I call myself the optimistic realist. You know, I like to be optimistic about the fact that we have opportunity. I mean, I look at someone like Brian today. Look at him. I mean, he looks fantastic. He looks like he's ready to get back out on that basketball court, right? The realism is that, you know, this is a disease we haven't cured, and it can come back, and it can come back with a vengeance, which is why it's so important for us to do the work and the research that we do. But it really is remarkable that myeloma has gone through such an evolution.
Dr. Cole, that's great news to know that the survival rate has increased significantly. Dr. Cole, what is a traditional course of treatment when somebody is diagnosed?
So that's of course, I'm going to say that's a great question.
Well, I hope I got some good questions.
So, you know, just like Dr. Mchale said, you know, back when I had a high top fade, and that actually did happen. You know, we were using chemotherapy, and it wasn't good. Now we, just like he said, the advancements are just incredible. And the more my hair came out, the better things got with myeloma. And now we use immune therapy. So the immune system, we harvest the power of the immune system to go after the myeloma. We use a drug which can actually turn that protein production of the myeloma cell against it. So it just targets the myeloma cell. There's no other cell that's producing that much protein. And one of the drugs that we use turns that protein production against the myeloma to go after the myeloma. And then there's a drug related to thalidomide way back when that gets the T cells in the body to go after the myeloma. And it poisons the myeloma cells specifically with leaving the other cells alone. So we have a very specific therapy now for drugs, which have response rates up in the 90, 95 percentile. When I had hair, that was more like 30%. And the fact that we can get that, I can talk to a patient and basically say that you're going to respond to this regimen. And this regimen is target specifically these 4 drugs plus steroids, because we've been using steroids for about 50 years. We still use steroids because that poisons the cells too. But that 4-drug combination, all those points of the immune system, poisoning the cell, targeting the cell, gives you those incredible response rates. Then we add on 1 dose of chemotherapy that Byron can talk about, using that stem cell transplant. So we do the right hook. We do the right hook, then the left upper cut. With that 1 dose of chemotherapy, knock the myeloma out, then do maintenance therapy, which stands on his chest.
Brian, you want to jump in there? And
Oh yeah, I absolutely remember that experience. It was something else. It was the closest thing to coming to grips with, you know, your mortality. It was a heavy dose of a cancer drug that took your immune system down to 0, right? This chemotherapy treatment. And it was all designed to literally reboot your system after the bone marrow transplant took place. So after having that chemotherapy, they injected me with T cells that were cultivated from my own blood system. It's called autologous bone marrow transplant, as opposed to one coming from another donor. And that actually happens to be, of the two, the most preferred method of re-injecting or reintroducing that blood back into your system. So it took about 90 days where I had to be out of the public domain. I had to be quarantined and couldn't be around any kind of germs. Couldn't go to the games and watch the Atlanta Hawks or the Knicks play. So it was worth the wait, because after that, I recovered very well, and just followed my doctor's advice going forward, and it's been great since then.
That is
Wow,
fantastic.
so glad you're doing well, my friend. I'm sure
Thank
you're
you so
doing
much.
better than the Knicks, actually. But I'm really thankful to hear how you've gone through that process, and that autologous stem cell transplant that you've described is still that. What did you call it, Craig? The left upper cut. We're still using that, but the day may come in the future with all the research and the work that we're doing, we may be able to skip that. We may be able to not bring that immune system down to zero as you've described. We may be actually able to do some really fancy things with someone's own immune cells and actually train them to directly attack the tumor, instead of just kind of wiping out the bone marrow that we've done with the autologous stem cell transplant. This thing called CAR T cell therapy and the different types of CAR T cell therapies that we're involved with now. I mean, let alone when Craig had hair. I mean, not long ago, this was like a Star Trek phenomenon,
Sure.
But we can literally,
Absolutely.
this is what we do in our trials now. We take T cells out of a patient and we train them. Essentially, we put a receptor on them that is specific to their myeloma, and we multiply them in the lab. That's something we couldn't do for many years. And then we reinfuse them into the patient, so that these T cells, now that have a honing mechanism for that specific myeloma cell, can go and destroy the myeloma cells and leave the other good cells behind. As opposed to the transplant that Brian had, where basically we just blasted the whole of the marrow. It was like burning the whole lawn to get rid of the weeds. Now we have a kind of weed killer that only hits the weeds and leaves the good grass behind. And that's really what the future of treatment of myeloma is going to be like.
That is fantastic, fantastic. So there were, and if you're just joining us, we are talking to Dr. Cole, Dr. Mchale, and Mr. Brian Daly about multiple myeloma. September is Blood Cancer Awareness Month, and myeloma is a kind of blood cancer that is disproportionately impacts Black Americans. And so we're talking about myeloma here tonight for a moment. There have been a couple of interesting questions from our audience. So I'm going to take a moment, throw them by you, and just kind of get your responses. There was one here, and it says, if you clean the lymphatic and endocrine system, well, will that work in terms of trying to prevent myeloma from happening? What say you about that?
I think that there are alternative therapies or complementary therapies, I should say, that people can do. But really, myeloma is when those cancer cells really start to do the mutation part, that it is pretty unavoidable, and that you have to really target those cells specifically. And so, when I have patients that look at, alternative complementary medicine, is just what it sounds like. It's complementary, that we talk about it, we work with it, and we run those complementary therapies alongside, as long as it's safe, alongside our standard therapies. But does that kill myeloma alone? That it doesn't kill or prevent myeloma. Just like Dr. Mchale mentioned, myeloma is something, it starts from a precursor disease that called MGUS, or monoclonal gammopathy of uncertain significance, long term, for a condition where you have tiny amounts of those plasma cells, and a lot of people actually have that. Only a minority will ever turn to myeloma. And once those cells start to kind of start their path, for some people, again, some of the alternative therapies, we would love for them to work, but we just haven't found that answer quite yet.
Gotcha. Yeah, I would say, from a lay standpoint, I don't, as long as it's safe, there's nothing wrong with doing a cleanse. I mean, it's, clean those symptoms out, but definitely with a condition like myeloma, I would definitely want you to be aligned with a great specialist like Dr. Mchale or Dr. Cole here.
Yeah, I guess the only thing I'd add to that is I hear what you're saying about cleanses and so on, but one area where I'm always a little bit more nervous is when people say, oh, doc, I found a way to get a real good immune booster. I got to boost my immune system. And there are some natural ways in which that happens, and we can think about antioxidants and so on. But you got to remember, myeloma is a disease of the immune system. So we got to be careful what part we're boosting, right? Because there have been products and plans in the past that have actually worsened the disease. So I think it's always good, as you say, to have a conversation. And docs like Craig and I, we really try to be progressive and open-minded, and we want to work with others. And there are alternative ways and naturopathic ways that we want to support and help. But we have to always be wise about how we approach it and recognize that, there are tried and true things, and there are things that are more theoretical.
One more question from the audience is, why do doctors allow the multiple myeloma cells to smolder before taking action?
Oh.
Yeah, this is a great question. Maybe I can start on this one, Craig, and you can back me up. Craig commented that we know that there is a precursor condition to myeloma, and that phrase that he commented on, MGUS, or monoclonal gammopathy of undetermined significance, was actually coined by my hero and the man who recruited me to Mayo Clinic, Bob Kyle. Is really in many respects the grandfather of myeloma. And if we look at that, if I look really carefully, somewhere between 5 and 10% of everybody over the age of 40 and higher incidence in the African-American population will have a tiny amount of that bad protein that Craig mentioned, either detected on the serum protein electrophoresis or those light chains. So we're clearly not going to give 10% of the world chemotherapy, right? And the reality is the vast majority of people who have that, it will never develop into an active cancer. It just sits there, just a small amount. It's almost like saying, if I biopsy the prostate of every man over the age of 80, I tell you, 20 to 25% of them will have a tiny amount of prostate cancer. But it's so tiny that it wouldn't grow to be significant until they turned 150. So we're not going to do anything about it, because trying to do anything may make it worse than what it is. So MGUS is so common. There's only a small fraction of people that will go on to develop what we call smoldering myeloma, which is kind of like the next phase of what happens. And then there's the true active myeloma that we're discussing tonight. So smoldering myeloma is less common, of course, than MGUS, but it's also in a similar situation where not everybody with smoldering myeloma will actively become myeloma. I wouldn't look at a woman with breast cancer and say, look, it's just a small amount of breast cancer. Let's just leave it there and wait and watch, because we know it's going to grow. But for the majority of smoldering patients, it won't grow. And this is where some of our research and work is going on now, trying to understand, why does it grow in one person and not the other? So the reason why we don't want to treat people, to answer Dr. Wilson's question, is that there are people that we know will never develop active myeloma who have smoldering disease. And we don't want to give them the risks of chemotherapy and all of those challenges, when in fact they can stay on my favorite drug, nada, right? Nothing. I mean, that's a great cost, great side effect profile. Every insurance company covers it. I mean, I say that a little bit tongue in cheek, but if you can keep patients on nothing, and their risk isn't high that they're going to develop active disease, then that would be better than treating them. Although we are now, Craig mentioned CRAB, we are sort of redefining myeloma a little bit, so that people who historically were thought of as very high-risk smoldering are actually true myeloma now. And that line may move a little bit more as we understand the disease better.
But I think that that question is the one of the number one research questions in myeloma right now. And I smile because it is, I think it's one of the most exciting areas for, why do people get myeloma? Why do Black people get myeloma? The research that we're doing, why aren't we treating smoldering myeloma? It's because we need to understand more of the biology of how this disease works. We've done incredible things, and Dr. Kyle has done incredible things helping us define this. But now to figure out who, just like Dr. Mchale said, who are those smoldering patients needs treatment, who doesn't? And that's a biology question. Why do Black people get this and why other people don't? That's a biology question. Right. And people being enrolled in clinical trials is how we answer that. And I hope that in the next few years that we'll be on this show and we'll have an answer for that and then talk about cure.
Well, when you come back in the next few years, I need you to bring a picture of you with that high top fade. I have to see that. I have to see that. Yeah. That is going to be the question and the statement of the night.
Yeah,
I'm going to need to see that.
You'll ask the picture with the perm. No one's going to see the perm picture. No one. That's off limits.
But so Brian, in all seriousness, too often when we talk about somebody being diagnosed with an illness, we talk about treatment, we talk about medications, surgeries, things like that. But we don't talk about the mental side of what the patient is going through, right? And so what that experience is like, one, to hear that diagnosis, and then your doctor starts talking about treatment plans and all those things you have to go through. Now you talk about being quarantined for 90 days. Help our audience understand what that process is like from a patient perspective, mentally having to deal with the treatment, the chemo, the surgery, and the kind of the existential crisis that gets created when you get diagnosed with myeloma.
Yeah, that's a very good term to use. There is a thing called Chemo Brain, right? And what that is, it's when the chemotherapy treatment, the drugs from the chemotherapy, actually impacts your brain, right? And it can manifest in the form of depression, fatigue, any number of things that will compromise your emotions. So going into this thing, you really have to be prepared mentally and as well as, hopefully having a good support system behind you that can take care of you. That's important as well, both physically and for your mental welfare. But I was prepared. I did enough research as I was going through this journey to know that I had to be vulnerable, right? You have to accept that as a patient. If you want to come through this thing with the best potential outcome that you can give yourself, everything else is going to be, a result of God and science, in my opinion. But you will be compromised. I mean, I can recall clearly, watching what's the name of that show? This Is Us, my wife, and just breaking down and having an emotional response, to what I was watching. And that's not me. I mean, it's not something that I would have normally been affected by, but it will impact you. Fortunately, I did not experience depression, but I could clearly relate to those people who go through that turmoil. And it's something you just can't help. So just be prepared for that is what I say. And most of all, be your own best advocate. Look out for yourself as much as you expect other people to look out for you.
Ellis, can I just add to that? First of all, Brian, thank you for sharing that. Your honesty, your dedication, and the work that you do at the LILS, and just being here tonight is an inspiration to me, and I mean that genuinely. I say it all the time. It's one of the things that I like to teach every resident student who works with me. I do not treat myeloma. I treat people. Okay. And as we as physicians, as we look to our patients as real, genuine people, and not just, someone with IgG kappa myeloma that requires an autologous stem cell transplant, and that transforms a world of difference, because we've learned that even that relationship between the healthcare provider and the patient has a significant impact on the outcome of that patient. Yeah. Along with, as you've said, the resources that are available to them, and I'm sure Ellis will get a chat about it in a few minutes, but the care partner that you have and the family and the support network you have around you is so critical, especially in a disease like myeloma that can affect so many organs, that can affect someone's lifestyle so dramatically that may require a stem cell transplant. This is not just like taking a pill every day, although sometimes that's ultimately what it is. Very often, especially in its initial treatment, requires some very intensive approaches. And so I just appreciate you sharing that with us tonight.
Yeah, absolutely. I consider it, I tell people, you've got to put on your armor, when you prepare for this journey, because it's going to be tough.
Yeah, I mean, I think that one of the first things I tell patients when you had asked earlier, about when we diagnose patients, and one of the first things I tell patients is, the first thing you need to do is really get your team together, pull your team around you, because there are going to be days where you're too distracted or you're too tired to hear some of the things that we're talking about that day. When I'm sharing good news, sometimes you need someone else there to celebrate with you. And so pulling your team around you. And we did a survey a few years ago and found that about 70 to 75% of myeloma patients that have depression won't tell their doctors unless they're asked. And when I told doctors that, they were just like, "Oh my goodness, we can help that. We can deliver the tools to lower the protein, but it's so important for patients." And again, I appreciate what you said, because you need to tell your doctor that so we can help you.
Yeah, I want to just add on to that, Dr. Cole. That's a very good point. I did go to therapy as recommended by my oncology team.
Mm-hmm.
And it was so helpful, because you have to really understand why you're going through, this, psychological journey while you're healing. And it's important to understand that, because, if you don't understand it and you don't know why things are happening to you, and no one else around you can explain it, and it makes it that much more difficult to keep your spirits up, and which is going to help you hopefully, recover.
Yeah, and I want to kind of point out some of the things that we in this conversation that Brian has been saying, that this is applicable to anybody. So number one, you've got to stick to it. You got to be your own advocate. You got to do those follow-ups. When they give you that referral out to somebody else, follow up, right? Continue to follow up until you get the answer that is satisfactory for you and your physician, so you can get the answer that you need, so you can get the right treatment. Number two, Brian talked about being vulnerable, right? Having to open up to friends, family, your coworkers, whatever, talking about that. He built his team, and then he leaned into that therapy, right? And understanding, hey, this is a challenge. I cannot just, and I know we, especially as Black men, because there's 4 Black men on this panel, we always get that suck it up mentality. This is not the time for that, right? Mm-hmm. This is not time for being macho. This is the time to say, you know what? This is a life-threatening situation, and I need all hands on deck helping me get through this process, physically as well as mentally. So thank you for that. And just I want our audience to really recognize that. And there's some people that are supporting you in the comments, Brian. So, and really just understand that being your own advocate means that all around every day, and having, and including that healthcare team. Dr. Mchale, I want to talk to you about a couple of things that I know you've got another event, so I want to be kind of respectful of your time. Let's talk a little bit about disparities, right? Because we understand that this particular condition has a disproportionate impact on Black Americans. We understand that across all healthcare conditions, there's some disparities. So what are the disparities in the multiple myeloma, and what can be done? I know you don't have if you could wave that magic wand, you would have been waving it all over the place by now. But what can we do in order to chip away at the disparities that Black patients are facing today?
I wake up every day trying to make a bigger wand, right? And a better wand. And,
Harry Potter, let's go.
we could talk about this for hours. Let me summarize some really key that are frankly sobering and disturbing statistics. We've already commented that myeloma is twice as common in the African American population. But perhaps the most distressing of all disparities is that the average survival of a Black patient with myeloma is half that of a white patient with myeloma. Mm. In fact, it may be the most disparate of all cancers within the African American community. We see health disparities, not to make light of it, in lung cancer and colon cancer, prostate cancer. The most dramatic is in myeloma. Now, there's hope for lots of different reasons. Maybe the most hopeful statistic is that in a large VA study where at least people were theoretically treated in the same way, given the same access, actually survival in the Black patients was superior to white patients. Okay. Because we know the biology is a little bit different. We do all these fancy tests in the bone marrow to look at the genetics of those plasma cells. It's more likely in a Black patient that they're going to have fewer of those what we call high risk features than in a white patient. So you would think they would do better, but we don't do better. We do worse. We do so much worse that it's literally half, and that's the tragedy. And we know that the cause for that is so many different levels. So you ask me, what is the solution? Well, we have to look at all those causes, everything from systemic racism, the way the society is structured, the way the healthcare system is structured. One of the big disparities we've already commented tonight, Ellis, is the delayed diagnosis. Yep. Early and accurate diagnosis, and then critically important is access. And sometimes I try to summarize access with 4 T's. There are 4 things that start with the letter T that we know help people with myeloma. Sadly, we've shown that there's a disparity in all 4 T's for African Americans to get access to triplets, or those 3 drug combinations, transplants like Brian described, trials, clinical trials are significantly fewer, and then that fancy treatment I described, the CAR T cell therapy. So whether it's triplets, transplants, trials, or CAR Ts, we've seen that disparity where African Americans have less access. So what do we do about it? Well, no one has the perfect answer. I can tell you in the work that I do at the International Myeloma Foundation, we've created a program, and you heard me talk about it, Ellis, and Craig is a big part of it. And I know the LLS and others are doing fantastic programs as well. But our program is called the MPower program. It's M standing for myeloma-power. It's kind of a play on words that we want to empower patients and communities to change the course of myeloma, because that current course of myeloma is not acceptable. And it's really based in 2 major modalities. Number 1, deep community engagement, working with the medical and non-medical community to teach the public about what this disease is, exactly what you're doing tonight with us, Alice. And God bless you for doing that, to give us a chance to explain what the signs and symptoms of myeloma are. And we're partnering with everybody and anybody, medical, non-medical. Today I was on a call with Joseph Mchale, former president of the National Medical Association. We work with the Black Nurse Association, fraternities, sororities, you name it, to raise awareness deep in the community. And part 2 is to work within the healthcare community, in particular primary care physicians, to go over what Craig shared with us about making the accurate diagnosis, distinguishing it from diabetes, making a timely referral, all the while trying to increase and encourage access to these critical therapies. And so influencing the government and the regulatory authorities and industry and the healthcare systems to do it. It's a complex problem. It's going to take a complex solution. Obviously, people want to read more about it. We appreciate that you put up the empower.org, empower.myeloma.org website that people can learn more about it. But at the end of the day, it takes a desire, no matter what your race and background is tonight, it takes a desire for this to happen, because we can do it. We have seen this happen in different jurisdictions and areas where that disparity has been reduced. So I do think it's doable. We just have to all work together to make it happen.
Well, yeah, that's fantastic. And so I put the website in the comment section, so you can click. Don't click now. We're wrapping up. So you can click after the show, but you can also click and find it there on the site. Dr. Cole, one of the things that's a buzzword in healthcare right now, well, buzzwords, is clinical trials. Yeah. So could you help our audience understand the importance of clinical trials, and more importantly, the importance of Black participation in clinical trials?
And that was, how do you narrow those disparities down? One way is clinical trials. The the hottest therapies, the most important therapies, the best therapies are in clinical trials. If I had the opportunity to go into the fastest race car that you have, I would sign a form and jump in that race car immediately, and that's what clinical trials in myeloma, that's what that is today. And one thing that we know, another statistic is that we know about 20% of the myeloma population in the United States is of African descent, or Black people. However, involvement in clinical trials is only like 4 to 5%. And how do you know? The first thing I tell our trainees is, when you read a clinical trial, when you read a paper about how to treat myeloma, is the patient in front of you reflected in that trial? Because if it's not, then you have to worry a bit about what happened. So being involved in clinical trials is a bonus, because you get the newest therapies. These people worry about randomization. Am I going to be randomized to a placebo? You can't randomize people to placebos anymore. It's against the law to randomize someone to a placebo. People in clinical trials get the best care available, or they get the best care available plus something new. So no matter what, if you're involved in a clinical trial, you're going to get the best care, and you're going to get a lot of attention. There are going to be nurses and research coordinators and doctors that are going to be watching and helping you. And you get a lot of support on the clinical trial. So the patient benefits from being in a clinical trial. We don't do guinea pigs. Dr. Mchale mentioned earlier that the breakthroughs in myeloma are breathtaking. They are breathtaking. So the clinical trials that are out there are the cream of the crop of the new therapies that are out there. And so you're not going to go, when you go on a clinical trial, you're not going to be given some guinea pig therapy. You're going to be getting the best therapy that research can give you today. And the more people of ethnicity, the more Black people we have in clinical trials, the closer we can get to that cure. So you're helping yourself, you're helping your community, you're helping your family by being on clinical trials. And the atrocities of the past are really behind us, thank goodness. Thank goodness. We have to do, Dr. Mchale and I have to do lots of training in order to be a clinical trial, in order to enroll patients in a clinical trial. We have to go through training, and we have to repeat that training every couple of years. And part of that training is being aware of what happened in the past, so it'll never happen again.
And if I can just add to that, Craig and I do a lot of this work together, where it's understanding the past, but it's also being very much in the present. And part of the challenge, and I see some comments saying, part of the challenge has been lack of education at the lay level, like Craig has just explained, but also as us as practitioners. We need to take some responsibility on this, that we need to practice more culturally sensitive care in what we do. We need to recognize that there may be a fear, there may be lack of trust. If we're not going to build trust with our patients, they're not going to go into clinical trials, or they're not going to go to transplant and those other T's for that matter. And so the onus is on us as well as physicians, that we build that trust, that we're sensitive to people's hesitation, that we explain it in a simple way, and that indeed we present them the opportunities that could be available to them. One of the things Craig and I did an interview even earlier this week, as you may remember, Craig, where we were discussing this exact point, and how very often in most cultures, but particularly within our cultures, where someone may want someone else from their family there to help make that decision. And if I, as a doctor, don't look to my patient and say, is there somebody that's really important to you that you want to have this conversation with? And now that we've got cell phones and computers and everything, more often than not, we can either FaceTime them in or just bring them in physically so that they can sit down and have that conversation. That can make a world of difference to a patient, so they don't feel that they're making those decisions entirely or on their own. So it's on the community, but it's also on us as the docs.
Yep. Fantastic. So we're coming up to the end, close to the end of our hour. This is flown by. So we're going to take some time now here to do some final thoughts. I know Dr. Mchale, you've got to head out. You've got another. He's hot. You see, we get the best. We get the best. He's in demand, right? He's in demand. It's like he's going to be on Showtime and Netflix and all that. He's in demand. So Dr. Cole, what are your final thoughts? What would you want people to leave with this from this program tonight?
That there is so much hope in myeloma. We've come so far with myeloma therapies, with myeloma with the diagnosis of myeloma, and more than anything, that there is an awareness in the community at large about how important Black patients are in myeloma. And everyone is now really working hard to bring awareness of this disease. So I give my utmost thanks to blackdoctor.org for having us come in today to talk about this disease and tell you that there's good news, that there is hope for myeloma, and there's hope for Black patients with myeloma. There's hope for all patients with myeloma. And I have a high level of certainty that in the very near future, I will have to go to McDonald's in order to find a job, because there won't be myeloma doctors. So if you see me at Burger King, just say, "You were that myeloma doctor." I said, "Yeah, but we cured it. We cured it." But
I'm gonna send that clip to McDonald's and Burger King. He's got but that's that food's not good for you. We should eat something healthy like salad. Salad.
You're right. My wife's a dietitian. She'd kill me if she heard me say that. But that's how close we're getting.
Yeah, Dr. Mchale.
You said it beautifully, Craig. I want to leave us with hope. As I said, I'm the optimistic realist. So that's the optimist. The realist part of me is that myeloma is still killing people every day, and preferentially killing Black people. And so we have more work to do. And this is part of the work, raising the awareness around it. That's what Blood Cancer Awareness Month is about. We have a campaign at the IMF we call "Do You Know Myeloma?", where the KNOW, but the NO in the middle is a different color, because we want a day when Craig is working at a healthy restaurant where there is no myeloma. But right now, we need to work together to make this happen. There are challenges. There are great, hopeful research projects and trials being developed, but there is still a tragedy. And so we want to support people through it. We want to make sure that people like Brian are given all the resources available to them to support them through this journey.
Absolutely. And Brian, you get the final word. You can kind of let us know what's happening at the LLS, and then any final words you want our audience to know.
Yeah. First of all, I want to just thank both Dr. Mchale and Dr. Cole for their commitment and the work that they do. It's fantastic. The IMF is a terrific organization, and we work in the same space to help, hopefully at some point, cure cancer. But I want to just say that we should recognize that when we are talking about this disparity, as far as this disease is concerned, this is just one of many other diseases. I think when the medical community can address these disparities, it's going to be a win for everyone, not just the underserved population. And lastly, I wanted to say that the Leukemia and Lymphoma Society and the Myeloma Link Initiative is there for patients in those underserved communities who need assistance with financial cost of going through that cancer journey, support from a clinical trial perspective. If you have questions about what it is and why you should participate, nutrition experts on staff, and we also advocate through legislation for patients and families. So with that being said, thank you, Ellis, for the opportunity, and we look forward to next time.
Absolutely. Well, I want to thank all of our guests, and also make sure you go to lls.org. It's there on the screen. They are a fantastic organization. We have worked with them multiple times, and it's just been a wonderful experience. We want to continue that relationship. Finally, I would just say this has been a wonderful conversation. Thank you, Dr. Cole, Dr. Mchale, Brian. This is fantastic. We're going to keep banging this drum. We are not repetition. We're going to keep talking about myeloma until Dr. Cole, we're going to put Dr. Cole out of work. We're going to put Dr. Mchale out of work. We're going to put, and it's just going to be LLS. That's it. It's going to be, they're going to be dealing with leukemia and lymphoma because we got myeloma taken care of. So we're going to be working into it. So again, we're going to replay this tomorrow morning. Share this with a friend. I hope you got something out of it, kind of that 360-degree view of what is multiple myeloma, the importance it is for our family and for our community. Know what you're talking about. Be empowered. Understanding, follow Brian's example, be your own best health advocate. And yes, I know I saw there's a comment, how can we keep in contact with Dr. Cole and Dr. Mchale? They're fantastic. I would say reach out to the Leukemia Lymphoma Society, and Brian and his team over there do a wonderful job. Also reach out to the International Myeloma Foundation. You can find information, and Dr. Mchale is the Chief Medical Officer for that organization, so you can get as much information from those two gentlemen as possible. And Dr. Cole is he's steady educating. He's at Michigan State. So if you're in Lansing and get multiple myeloma, you might be lucky enough to get Dr. Cole. But there's just been fabulous partners, and I couldn't thank you enough for joining us here tonight. So that's it. Blood Cancer Awareness Month of September. Make sure you're getting screened. Make sure you're monitoring your system. Make sure you're getting everything checked, your blood sugar, your heart, your blood pressure, all of you should know what your numbers are. If you're male, prostate. If you're a woman, you should get your breast exam, all of that. So please get yourself checked, get fit, and get moving. So with that, we're signing off. Thank you all for joining us, and we'll see you next time.